Okay, hello everybody. Thanks for coming. And today it's a real pleasure to have Professor Don Des Jarlais talk about the topic that I think he's the ultimate expert in the world. And I think everybody knows Don. He's a professor in the department. He's co-director of the CEDAR, and he's been doing research in drug use, HIV, and HCV for many years. I think one of the most remarkable things is he's the PI of the risk factor study that started in 1983. It's fantastic, and let's hope the study continues in spite of the current environment. He's literally a legend in the field. He's published in major journals, and today he's going to talk about the history of the epidemic in New York City. So yes. Thank you, Don, for having me.
Thank you. Yeah. First, I'd like to say I'm very glad to be here giving this talk. It was an emotional experience for me preparing this and reviewing 40-some years of my life. The title of the talk is something we heard on the streets of New York in 1984. A person selling syringes saying, get the good needles, don't get the bad AIDS, showing that the drug-using population was responding to the HIV epidemic. They clearly did not want to get infected with AIDS. Entrepreneurs were taking advantage of that by painting clean needles and selling them on the street. And this was at a time when the general population and people who specialized in substance use thought people who use drugs are self-destructive, but they'll never change their behavior to avoid AIDS. Do I have to point it at the left? Okay. So yeah, I'll be talking about the first decade of the epidemic, or the first known 10 years of the epidemic, which are about 81 through 91. And they'll primarily be through the risk factors grant. Proposal was written in 1982, funded on the first submission. We've continuously renewed it every 5 years. It is now pushing up into year 41. It's mostly serial cross-sectional surveys, although we have the capability of recapturing people who've been in the survey more than once. We allow people to be in once per year, but we get a fair number of people in different years, and so we can do cohort studies with those people. We primarily have focused on people who inject drugs, but there have been a number of times when we've included people who do not inject. We have well-developed questionnaire that parts of which we've been using throughout the whole study. We do HIV and HCV testing. We're now doing urine toxicology, and we do special sub-studies every now and then. The early co-investigators included Michael Marmer of NYU, Tom Spira of CDC, David Sensor, Sarah Beatrice and Polly Thomas from the City Department of Health, Donna Milvan, Stan Yankovitz from Beth Israel Medical Center, and Mary Jean Creek from Rockefeller University. I really want to acknowledge the project staff, most of whom are here. We've had a number of project directors, co-investigators, including Sam Friedman, Dennis Bayonne, Terry Perlis, and Jonathan Fieldmeyer. Courtney McKnight has moved up to being an MPI on the study. I want to acknowledge the statisticians, Patricia Friedman, Camille Ariste, and Alan Wang also. The administrators, Judith Milliken and Winnie C. Everything would have fallen apart without those two over the years. And then in particular, the interviewers, John Weber, who was the original interviewer back in 1984. The current interviewers, Martha Marley, who recently left the study.
1984.
Okay. The HIV/AIDS epidemic among PWID in New York is the world's largest HIV epidemic among PWID. There's nothing else that's close. There are over 60,000 recorded cases of AIDS among PWID in New York. And over 100,000 infections. There are a number of cases that never got recorded because there wasn't HIV testing early in the epidemic. And there were undercounts, particularly of deaths because of lack of testing, misidentification of AIDS cases. The early definitions of AIDS cases were based on men who have sex with men. And so there were a lot of people who inject who got missed by that definition. Part of that epidemic is mother-to-child transmission. That was politically a very important part of the epidemic. And then there was sexual transmission to partners who did not use drugs, and also sexual transmission to people smoking crack. The peak of the new AIDS cases occurred around the early 1990s in the US. At about 25,000 per year. At that time, almost 10% of all new cases of AIDS in the country were associated with injecting drug use in New York City. So New York City, the people injecting in New York City were a very, very critical aspect of the entire US epidemic. In the decade of the 1970s, before HIV was discovered, New York City was in a fiscal crisis. You might have heard of the headline from the New York Post to the president, Ford to city, drop dead. As part of the fiscal realignment, the State Division of Substance Abuse Services took over the funding of all drug treatment programs in the city. They were taken away from the City Department of Health and given to the state. The State Division of Substance Abuse Services had a research unit that I was part of, but it was almost exclusively focused on epidemiology and treatment evaluation. It really had no component for medical studies. At that time, NIDA was not interested in infectious diseases. The director of NIDA said, we don't study infectious diseases. They were focused solely on drug-using behavior. However, the medical examiner did study deaths of people who use drugs, and that was an important aspect of the HIV epidemic. Also, we had a heroin epidemic in the 60s and 70s. That epidemic, particularly the heroin part, led Governor Rockefeller to change the drug laws in 1973, making them much more punitive with potential life imprisonment if you were caught selling drugs 3 times. There were also very strict narcotics paraphernalia laws, which included syringes. Also, also an important part of that epidemic was men who have sex with men and injected drugs were integrated into the PWID culture. In other cities, men who have sex with men injected would be injecting amphetamines only and really separate from the street heroin using culture. But in New York, there were enough men who have sex with men and who injected that they were really part of the heroin culture. And this allowed for rapid bridging from men who have sex with men to people who inject. At the time, it was also the social norm to share your injection equipment. It was considered a friendly thing to do, and that people would do it for each other. There were also a lot of shooting galleries where people would take their drugs, go to inject, rent space in the shooting gallery, either for a few dollars or perhaps giving the gallery owner some drugs. And they would use a syringe, they'd rinse it out so that they could use it again. So that rinsing out actually facilitated transmission of HIV from person to person rather than doing anything to stop it. They basically wanted to avoid clotting of the syringe rather than trying to clean it or disinfect it. AIDS was first discovered in the US among men who have sex with men in June 1981. That was followed a few months later by this discovery of HIV/AIDS in people who inject drugs. Then in the fall of 1982, Dr. Charles Sharp, who was a NIDA program officer in charge of nitrates or poppers that were used by MSM. He ran the studies on poppers. He came up to New York. He met with me, Doug Lipton of DSAS, Michael Marmer of NYU, Donna Milvan, Stan Yankovitz from Beth Israel. And we met in the executive offices of Beth Israel Medical Center. And we reviewed what was known about AIDS in PWID at the time, which really wasn't much. That review did not take long. But it was clear that New York City had more cases of AIDS among PWID than any other city in the world. So that there was a consensus within the group that New York City researchers had an obligation to write the grant to study AIDS among people who inject drugs. It was considered a modest problem at the time, but that it might become a really significant problem soon. This was known about the early AIDS cases among PWID in New York City with single digits for 1980, double digits from 80 in 81, triple digits in 1982, and 340 cases in 84. Pardon me, 83. So this was the background. The meeting in New York with Charlie Sharp was bridging between 82 and 83. But it was clear that there was a real epidemic going on here.
Don, can you go back to the previous slide? How much of an underestimation do you think those numbers?
I would say those numbers probably reflected a third to half. Okay, so the group decided, well, yes, we should write a grant. We really have to address this problem. We're probably the only city in the world that will have enough cases that we can do epidemiology rather than case histories. So the group agreed that we would write a grant. And then the question was, well, who's going to write the grant? And when that question was first posed by Charlie Sharp, there was silence in the room. And I grew up on military bases, and one of the rules of the military is you never volunteer for anything. But I decided anyway, I would go ahead and volunteer to write this first grant. At that time, I was the Deputy Director of Research for the Division of Substance Abuse Services. I was working with Vince Dole and Marie Neiswander of Rockefeller doing studies of methadone maintenance. In fact, we even published a paper in New England Journal on that. I had also worked with David Courtwright, a historian, and Herman Joseph to set up an oral history project where we were doing oral histories of people 55 to 90 years old to get their life histories of using heroin in New York City. The other thing is that I had a fair amount of flexible time. I didn't have to run a division or a unit. Doug Lifton was in charge of the division of research, and so he did all the administrative work on it. I didn't have any clinical responsibilities, seeing any patients or anything, so I felt I could probably make time to do this grant. The grant was a challenge, to say the least. It had to be state-of-the-art in AIDS, drug use epidemiology, drug use behavior, infectious diseases, immunology, laboratory procedures, and epidemiology research design. So it really was going to be a very broad grant and having to be state-of-the-art in a lot of different areas. Fortunately, Michael Marmer, Donna Milvan, Stan Yankovitz, and Tom Spear of CDC contributed to the writing of the grant. However, it was by far the most difficult scientific challenge I'd ever had in my life. Doing a PhD thesis was nothing compared to writing a grant that has to be really good in a lot of areas that you'd never studied. We submitted the grant in early '83. It was funded on that first submission starting in 1983. The study design was a comparison of 100 PWID with AIDS to 100 PWID without AIDS. That was going to be a real challenge. We were going to use a questionnaire. We did believe that there was an infectious agent, a new infectious agent, but getting at the behavioral specifics of how people got infected was going to be challenging because we didn't know when they might be infected. We had no idea whether specific drugs might be acting as cofactors for the infection, what the latency period between infection to disease might be, and whether or not there were anybody who had been infected with this agent who might have recovered. So all of those people and the latency period people might make finding those who are infected versus those with disease quite difficult. We wound up pretesting the questionnaire in hospitals, including Beth Israel and Bellevue. And for the people in the hospital with AIDS, death was certain. They knew that they were going to die. They might be discharged from the hospital this time, but they knew that people who had AIDS seriously enough to get hospitalized were going to die. It was also near for many of them. They were not expecting to leave the hospital alive. It was also painful that having these infections and everything, the opportunistic infections, was physically painful. Medicine was not very good at controlling pain with people with histories of narcotic use at that time. It's still not very good, but it was really terrible at that time. So they tended to be under-medicated and in pain. They were also lonely. They were not allowed to have visitors. The hospital staff would go into and get out of the room as fast as possible. Nobody knew exactly how this infectious agent might be transmitted, so they didn't want to spend much time in the rooms, so that the patients felt lonely and course, stigmatized. However, I had great admiration for those patients. They really worked hard to answer the questionnaire. I could see them struggling to remain conscious, that sometimes they would go into being semi-conscious, but then they would fight their way back to answer the questions. They struggled to recall the details of their drug use. I mean, this was going through a lot of their life history from the first injection on, so that there was a lot of sort of hard memory work trying to recall those details. And also going over the histories of their drug use when they were dying from the drug use was very sad. There was tremendous regret that you could hear in their voice that they had done these drug use behaviors. But they really did exhibit effort and commitment to participate in the research as much as any research subjects I've ever seen. They really wanted to do this well. They knew it wasn't going to help them to answer the questionnaires, but they believed that it might help some of their peers. Okay, so for me, the pre-testing was an intense emotional experience after the intellectual experience of writing the grant. I mean, I had, done occasional interviews with people with fatal diseases, but not that many interviews with people who are going to die very, very soon, including some who died within the week after my interview. I took the commitment of those AIDS patients to the research as a model for my own commitment to doing the research, that if my initial subjects could spend the last parts of their lives contributing to the research, I could certainly devote my career to doing the research. A couple of years later, I was going over AIDS death data, and I realized that all or almost all of those people I had been interviewed in the hospital were dead. And that actually brought tears to my eyes. The only time that's really ever happened in research. There were a number of research studies going on, especially the Friedland group at Montefiore that were doing clinical studies of comparing people with AIDS or pre-AIDS to drug users who didn't have any symptoms. There was the 1984 street study where the street outreach unit of DSAS went out on the streets to find out what was happening. And that's where the quote from "get the good needles, don't get the bad AIDS" came from. Then in 84 and 85, there was the development of the HIV antibody test. Montagnier and Barry-Sinisi worked on it at Pasteur. Gallo worked on it at NIH. I was affiliated with the Montagnier and Barry-Sinisi group through Tom Spira at CDC. So that the initial testing I had being done in my study was actually using the Montagnier and Barry-Sinisi formulation of the test. Then once the tests were officially developed, there was a large number of studies being conducted in the US and in Europe. We found great variation in HIV prevalence. Scotland was the most interesting variation, with 50% of people who inject in Edinburgh infected with HIV, but under 5% in Glasgow, with only about 50 miles between the two cities. And in Amsterdam, it was about 30%. Here in New York, Lower Manhattan was sort of the epicenter of HIV transmission, because you could follow HIV prevalence rates north through Connecticut and south through New Jersey. And the farther you got from lower Manhattan, the lower the HIV prevalence. And at the time, my office was in lower Manhattan, so people gave me some credit for being at the epicenter. In 1987, the International AIDS Conference was held in Washington, D.C., so that it received a lot of national as well as international attention. I gave the plenary talk at that conference and was tracing HIV back to the 1970s, looking at the factors associated with rapid transmission, the seroprevalence, or the percentage infected, was half of the drug users we were studying. We knew about heterosexual and mother to child transmission. And also that time, it was clear that the case fatality rate for HIV infection was approaching 100%, that there just did not seem to be anybody who got infected who did not die from HIV infection. This is some of the early data. We particularly were fortunate to have stored blood samples that were stored at Rockefeller University going back to 1978. And that was actually our first HIV positive blood was collected in 78. So we knew that the epidemic had really started in the 70s. And it was really not till late 81 that AIDS was officially observed in people who inject drugs. And you can note that within a short period of time, the prevalence increased greatly. This is a graphic reconstruction with the first cases of HIV among people who inject were probably around 1975. And then it increased rapidly from 78 to 81, 82, and then stabilized at 50 to 60% seroprevalence from about 83 onward. We were able to sort of reconstruct factors associated with rapid transmission. First, people who injected didn't have any idea that HIV was a local threat. That rapid transmission was going on without anybody in the population knowing it. There were also limitations on access to sterile injection equipment. I mentioned that narcotics paraphernalia was heavily criminalized. There was also high frequencies of drug injecting behavior, including injection of cocaine, which could be, inject every 20 minutes till you run out of cocaine. There were also large injecting risk networks. The shooting galleries exemplified that people would come into a gallery and then the next person would come in and use the same needle. There was not necessarily any social connection between those two people. So you had the chance for fairly close to random mixing. Okay. In the mid to late 80s, there was actually a considerable public health reaction to what was happening. The data that I presented at the AIDS conference was consistent with the smaller limited studies in the US and Western Europe. But everybody was getting very concerned about the possibility of rapid transmission. The data I showed from infection from the late 70s up to the early 80s was very concerning. That's 50% of the New York population was infected with HIV, was of course very concerning. And again, no evidence of any recovery from HIV infection is very concerning. That Washington conference did get great media attention, including stories in the Times, local TV, and national TV. And that conference really put HIV among people who inject on the map. That everybody in public health now realize that people who inject were going to be a big part of this epidemic. It led to activist concern about the epidemic, including with people who inject and their children as part of the population at risk for HIV. NIDA went from saying we don't do any research on infectious diseases among people who use drugs to becoming a champion of studying HIV among people who inject. They set up the National AIDS Demonstration Research, which funded about, I think it was 12 studies throughout the country, large cohort studies. There was a National AIDS Commission appointed to advise Congress and the executive branch about what to do about HIV infection. I was fortunate enough to be a member of that commission. World Health Organization set up a global AIDS program, originally headed by Jonathan Mann. And also I wound up doing a lot of travel, sort of spreading the word about what happened in New York with the hope that it would not happen elsewhere. There were initial developments around syringe exchange in the United States with the thought of a syringe exchange both gets a clean needle out and removes a potentially HIV contaminated syringe. So logically, this would be the best way of trying to reduce transmission. The AMFAR, the American Foundation for AIDS Research, funded research at the Tacoma syringe exchange that showed behavior change, people using drugs, reducing their sharing, and also showed that participants in the Tacoma syringe exchange were less likely to get infected with hepatitis B than people who lived in the same county and did not participate in the syringe exchange. Pierce County, where Tacoma is located, was one of the 4 counties in the US that the CDC funded for studies of hepatitis B. So this was the first biological evidence that syringe exchange would be effective. And then the National Academy of Science and the Institute of Medicine had various committees and reports, multiple books coming out examining HIV in the US. The National Commission did support syringe exchange. There was a report called the Twin Epidemics. And the National Commission was also very instrumental in the passage of the Americans with Disabilities Act. And we were even able to get people with histories of drug use as a protected class against discrimination. We had sort of hoped that maybe people currently using drugs might be considered as a protected class against discrimination, but that was a political reach too far. But we were able to get people with histories of drug use as a protected class against discrimination. That certainly didn't end the stigmatization of people who use drugs, but it did provide some legal backing for reducing discrimination. There was also very, very intense political opposition. This was really an extension of traditional stigmatization of drug use and racism, since a lot of drug use was concentrated in ethnic minorities. And it was also a function of the crack epidemic that was going on in the 1980s. So that crack users were not necessarily violent, but there was extreme violence around the distribution of crack. And it led to drive-by shootings in the Black community, which bothered everybody. There was also a moral panic around crack use that society as a whole was really, really upset about the use of crack. And this led to things like the much heavier penalties for possession of crack cocaine versus powder cocaine, the concern about crack babies, which turned out to be false. The babies with developmental problems were not, the problems were not caused by crack, but by other socioeconomic factors. It also meant when people would go out and advocate for syringe exchange, the counter would be, well, what are you doing about crack? That trying to say, well, we have to do something about needle-borne transmission. We don't know what to do about crack really, would lead to sort of disappointment in the community that you weren't attacking the problem that was causing the most violence in the community. This opposition was codified in law with the 1988 Helms Amendment to federal funding. That amendment was based on the FDA logic that you couldn't approve something until you had proof of safety and efficacy, and this proof had to be documented by the Secretary of HHS. So while you needed to have research support for safety and efficacy, they also banned federal funding of the research. And then when privately supported research did show safety and efficacy, the federal government still banned support for syringe exchange. So it wasn't just a catch-22, it was a catch-23 and a catch-24. In terms of my early work, in addition to working with the Tacoma Exchange and the Portland Exchange, I visited Amsterdam to see their syringe exchange in 1984. They had actually set up their exchange to control hepatitis B. They didn't know that they had HIV in '84. When I came back, I worked with the Commissioner of Health to set up a pilot exchange. We developed a plan that we felt would be extremely conservative in terms of not in any way encouraging drug use. But that plan was leaked to the police department, who really shot it down. They wanted to maintain criminalization of paraphernalia so that they would have a rationale for injecting drug users whenever they felt like it. A couple of years later, in 1987, we did get that pilot study approved. The pilot program was called A Bridge to Treatment. We recruited people who were on the waiting list to get into methadone treatment to participate in the syringe exchange. That way we could show that they would participate in a syringe exchange and still go on to drug treatment, so that the exchange was not keeping them out of treatment, not continuing their drug use. There were, however, a lot of political limitations put on that study. One was that the exchange could not operate within 500 feet of a school, and health department facilities were intentionally located near schools so that you could provide services to youngsters. So that we wound up with only one site in the city that was operated by the health department where we could do the syringe exchange. And that was on Worth Street, very near the police headquarters, which was not the most, the friendliest location. There was also intense political opposition here in New York. One city council member said that it would be genocide against Black. In 1989, David Dinkins was elected as the mayor. He was the first Black mayor in New York. And he decided to shut down the program. Clearly at that time, the program either needed to be expanded greatly so that it would reach a large number of people, or you might as well close it. We did know that it got people into treatment, but it clearly was not having an effect on the epidemic. And in a meeting with Woody Myers, who was the new chair of the Department of Health for the city, he said, "What am I going to tell the Black pastors about syringe exchange?" The pastors were clearly socially conservative, clearly very, very important in the Black community. So really, until that question could be answered, we were not going to have large-scale syringe exchange in New York City. However, there were activists, including ACT UP, who did start up syringe exchanges. They were very modest in scale, but they were there. And these activists got themselves deliberately arrested and there was considerable publicity about them getting arrested. One of the things they wanted to do was test the law about criminalization of paraphernalia. The defense was going to be, it was a public health necessity to distribute clean syringes. I testified in that, and the director testified in that trial. The defendants were found not guilty, that there was a public health necessity to distribute sterile injection equipment. However, neither the city nor the state government started to fund syringe exchanges after that court case. Everybody who had participated in it was really quite upset that the government was not stepping in to actually do syringe exchange. And at this time, the HIV cases and deaths continued to increase. These were the years where HIV cases among people related to injecting drug use in New York was about 10% of all the HIV cases being identified each year. Then a syringe exchange was started in New Haven, Connecticut. The mayor of New Haven had been a vocal opponent of syringe exchange, but then he visited the hospitals and he saw these Black babies dying of HIV infection. And he decided this was just morally impossible. You couldn't allow these young babies to die simply because you were insisting on criminalizing narcotics paraphernalia. They, with RWJF funding, they started a syringe exchange. Ed Kaplan developed a model, a mathematical model for studying HIV among people using the syringe exchange. Basically, what Ed did is they tested the syringes being brought back to the exchange. And they noticed that over time, the percentage of syringes with HIV in them was decreasing. So you were successfully reducing the chance that a needle would be with HIV in it would be reused. And you can think of that really as syringes flowing through the PWID population. And whenever you could take an infected syringe out of that flow and put in a clean syringe, you would be reducing the chances that somebody would get infected. Then in 1992, the state did a large-scale expansion of syringe exchange programs. And with NIDA and AMFAR funding, we started a large-scale study of the effectiveness of New York City syringe exchange programs in reducing HIV infection. This included 4 National AIDS Demonstration Project cohorts, a vaccine preparedness initiative cohort, and then a syringe exchange evaluation. In that syringe exchange evaluation, we sent our interviewers out to the exchanges. They would interview people, and then they would re-interview them when they came back to continue using the syringe exchange. And that those interviews included HIV testing so that you could look at HIV incidence in people who were repeatedly using the syringe exchange. And I mentioned we had AMFAR and some NIH funding for this. We wound up calling this the Lancet Syringe Exchange Editorial Study because after we'd collected the data and analyzed it, Richard Horton, the editor-in-chief of Lancet, visited New York. He met with my research group, we presented the data, and then he wrote an editorial in Lancet supporting syringe exchange. And then he felt morally obligated to publish the data in Lancet. Okay, this is some of the research design. We were measuring HIV incidence in people who used the exchange and some people who did not. I mentioned the syringe exchange study. And also there was the vaccine preparedness cohort and the high prevalence National AIDS Demonstration Project cities that included 2 cohorts in New York, 1 in New Jersey and 1 in Puerto Rico, because there was a lot of back and forth between New York City and Puerto Rico. And we had around 7 to 10 months of follow-up in each of these studies. This is some of the results. Note that the rate per 100 person years at risk for people using the syringe exchange or methadone patients was around 1.5%. The rate of HIV infection among people who did not use the syringe exchange in the high prevalence nadir cities or in the vaccine preparedness initiative was around 5 to 6. And that was really consistent when we looked at new injectors in the nadir studies for Manhattan and Brooklyn, where the rate was somewhat higher. So we did a proportional hazards regression, and using the syringe exchange, or not using the syringe exchange, had a hazard ratio of 3.5, significant at p equals 0.01. When we did a reduced model, the only thing that stayed as a significant predictor was not using the syringe exchange. So to move on to conclusions, the first thing that we really learned was that people who use drugs will change their behavior. They'll change their behavior to protect their own health, to protect the health of their peers, to protect the health of the community. That cessation of drug use is very, very difficult, but it wasn't necessary to get people to stop using drugs to stop HIV. We also learned basically that epidemics happen and you have to try to be ready for them. And that you also have to be concerned that epidemics may start and accelerate in highly vulnerable populations. And we learned that there's a big danger if you silo drug treatment and prevention from the healthcare system as a whole. That people who use drugs are part of the community as a whole. What happens in that population affects the community as a whole. And you can't just try to put the drug services in silos separate from community health as a whole. And one of the difficult lessons was that you should never underestimate the power of stigmatization to make a health crisis worse. We had seen multiple reinforcing stigmatizations of drug use and racial and ethnic minorities and a moral panic around crack cocaine, all of which delayed syringe exchange and made the problem worse. And that you really need coalitions to do something. We had a coalition among activists, community members, public health officials, and researchers. Members of all that group supported syringe exchange, and community members provided very important information for guiding the research. And we also learned that research is critical, that not all syringe exchange works. And some other prevention activities such as education and bleach distribution were not sufficient. That you had to have good going data collection to know whether or not what you were doing actually was working. And I mentioned that there were some syringe exchanges that failed. Typically, they didn't give out enough syringes, or they tried to pressure people who use drugs to go into treatment. And you have to keep at it. Persistence is really critical. Dave Purchase said that HIV prevention is never perfect and never finished, and that is really quite true. And basically, all of these lessons can be summed up in the ideas of harm reduction. I have a number of future topics to be presented some other time, including how to end an HIV epidemic among people who inject drugs, and we now have good examples of that. International dissemination, agent-based modeling, prevented epidemics, places that stopped an HIV epidemic from ever taking off, studies of the crack cocaine epidemic, and racial ethnic disparities over time. In our data from the 70s, we saw racial ethnic differences with whites having the least prevalence. And those continued up until really the end of the epidemic. And we think we know what was going on. And I would like to give some lessons learned from a late stage investigator to early stage investigators. One I mentioned, scientific research is a team sport. That this risk factors study was always a team effort. I mean, I was leading it, but it was really a team effort. I think we have between 200 and 300 publications, and with at least 5 co-authors on every publication. In terms of my own co-authors, I probably have 300 some. And then I'm also a senior collaborator in the Global Burden of Disease study, and probably have 1,000 co-authors from that. Some of the individual papers from that, where I'm a co-author, have 400 co-authors. I would recommend that as a study to get great epidemiological knowledge on every disease within 200 countries. In terms of being a good co-author, I feel it's critical to contribute ideas to the study. Don't be a passive ride along, but try to contribute active ideas to the study. Try to contribute written text. That if you're reviewing a paper, somebody else was the first author, and you say, oh, X topic needs to be discussed more, you should try to write some of that discussion. The first author will love you for doing that. And then when you're a co-author, you should try to think of bulletproofing either the paper or the grant. Try to figure out what the reviewer is going to poke at, and then solidify those areas. That will save the first author an awful lot of grief if you can anticipate where the critics are going to focus and then build up those parts of the study. Then finally, some sort of personal academic trivia from a late stage investigator. I have over 3 million frequent flyer miles. I cannot use all of them because some of them are on Eastern, TWA, Pan-Am, Northwest. You're familiar with your frequent flyer miles expiring? Well, my airlines were expiring. People who do a lot of international research tend to pick up diseases.
Yes.
And I had one very serious respiratory infection. I got it at a meeting at the World Health Organization in Geneva, where I sat next to somebody from an African country who was just coughing all of the time. And I just felt sorry for him at the time. But when I came back to New York, I was coughing. And I coughed for 3 to 4 months. It was particularly bad at night because if I lay down, the coughing would accelerate. And so I'd have to get up, and I was getting very, very little sleep. I saw some of the best infectious disease specialists in New York City trying to get rid of that disease. And they told me 3 things. First, we don't know what you've got, and we don't have any tests for whatever you've got. Second, on a more positive note, they said, well, you're obviously past the contagious stage because nobody around you is getting sick with it. And the third thing was also positive. They said, we don't think you're going to die from it. And I've had 2 serious cases of food poisoning where you feel like, you know, you're not going to die, but you feel it would be much more comfortable if you did. Okay. Okay, and okay, the final trivia point from the late stage investigator is that I've had office disasters every 10 years. The first was in 2001 when my office was in the World Trade Center when the planes hit it. The second, I had an office down in the financial district, got basically wiped out by Superstorm Sandy. And in 2020, I had an office here at NYU and COVID hit and the office shut down. So I'm sort of warning people for 2030, be careful about what might happen in this building. Okay, and the last little bit, I don't know how many publications I have. Because of modern computers, I publish under various names, including Des Jarlais as 2 words, Des Jarlais with 2 capitals but 1 word, Des Jarlais is 1 word with only 1 capital, Jarlais and Bay. Recently got an email addressed to Dr. Jarlais, Don DC, and I was impressed that they got my middle initial in and that they'd used a random number generator to put the words in order. Finally, somehow editorial manager thought my name was Dr. Yun Jin Kim. And they would repeatedly send me articles to review for journals. And for a while there, I was saying, no, I'm not, if you get my name this far wrong, I'm not going to review it. However, I got an email this morning saying that they had opened up a new journal on psychedelics. And if I wanted to publish an article, they would not charge me the author charges for the first year. So, or at least Young Jin Kim would not be charged. Eventually, I was getting tired of that, so I complained to editorial manager that Young Jin Kim was not my name, and they changed my name to Don Jarlais.
Still kind of wrong.
Okay, and so I'd like to thank you for your attention. I've really enjoyed talking with you. And any questions?
I have a question. Um, so
Want to hear the questions or?
yeah, I have one in the room. So thank you for this history, even though I've heard versions of this multiple times, it's nice to hear it all together. So I guess, given that you've spent the majority of your career studying HIV among people who use drugs, have seen the effectiveness of prevention efforts and of ART at preventing the advancement to AIDS, even at the population level. I was wondering if you can comment on, and this might go back to your 2030 point, hopefully not, but the fact that the HHS director does not believe that HIV causes AIDS, and sort of what your thoughts are on the future of HIV, very low HIV incidence, and also funding for prevention and treatment and research.
My thoughts are basically, I'm worried. You know, that the thought that an HHS director would not totally believe that HIV causes AIDS is really scary. Hopefully, there will be enough people in HHS and in Congress that there will not be actions taken on erroneous beliefs. But for vaccines, we're already starting to see that. I think the evidence for HIV as a cause of AIDS and the effectiveness of prevention and the effectiveness of treatment is really strong enough that those won't be challenged. But clearly we are, you know, seeing Agency for International Development abolished. And so a lot of funding that would utilize that science is now under threat. So I'm expecting more people to die of HIV, more people to get infected with HIV, more people to die from HIV, unless we can reverse these things.
Don, thank you so much for just tour de force. My question has to do with you. You beautifully brought forth this example of syringe exchange programs and how it took a combination of, scientific study, political advocacy, and really will in order to bring this to fruition. So I was just wondering if you had any thoughts about how, your experience there translates to the modern day efforts around harm reduction, with people with drugs, including syringe exchange programs, but more, naloxone. There's a lot more that's happening. So I was just wondering, is there anything that you learned, from that, the history of it, could apply to today's situation?
Yeah, I think that the two basic things were the persistence. You have to keep at it. Just because you show something works doesn't mean that it will maintain political support the whole time. And then I would say the other main thing is you have to continue doing research because things change, you get new drugs coming in, some of which have shown to generate HIV outbreaks. And so that you have to really keep the persistence going at the political level and also at the research level. You have to continue to study what's happening.
Oh, hi. I came across a lot of your essays, not even knowing that you were here. And I thought that was really interesting. So
That's the name problem.
your picture is actually in one of the journal articles that I read, which was I've never seen before. But one of the things that I'm actually really interested in understanding, you mentioned like coalitions between like activist organizations, and you mentioned like the work that you do at ACT UP. I guess in terms of research and then kind of like coalition with people that are on the activist side, I know like a lot of ACT UP folks, specifically ones that were like in treatment and data, like they had a lot of knowledge. How would you kind of like, on a researcher side, how would you get researchers to, become more aligned with folks from the activist side that have you guys have the same mission, but their mission is kind of like a little less aligned with what you're doing?
Yeah, I think, researchers need to realize that they need support in the community just to get good studies done and then to get good studies implemented, I would recommend that they spend time with people in the population being affected. I know for me personally, interviewing those AIDS patients in the hospital was really the motivating force for dedicating my professional career to dealing with this infection among people who use drugs. And also I found that a lot of the activists are fun to be with. So they do a good job of partying, they tend to have a good sense of humor, so that I would recommend spending time with them. The other thing I would recommend is serving on commissions. I served on the New York City AIDS Commission and the New York State AIDS Commission, and those included myself as a research scientist, but also activists, so that at the meetings and such, and after the meetings, you could just hang out and talk with people.
So just to let you know, we have to give up the room in about 5 minutes, so just as that.
So I'd
I'll
like-
just say as a student, I had a hard time finding your papers, Dawn, exactly because of the name issues.
Yeah, like I said, I've given up trying to count them. But if you have a specific paper you might want to find, come to me and I'll try to find out the pen name that I used on that.
Thank you so much. Don.
Thank you, Don.
Right.